If you guys could just bear with me here, we're having some difficulties with my child who's getting care. She has cystic fibrosis, and we're trying to coordinate about 14 different things. So just bear with me for 1 second.
Standard Care Pulmonology Specialist, how may I help you?
Yeah, I'm trying to get some care scheduled. I just saw our primary care physician, and we apparently need to get some more tests. We need to get to the pulmonologist. My daughter, Olivia, has CF, and we were supposed to coordinate something with you and then see an infectious disease physician. So can you help us get something put together?
Let me get you to our scheduling department. Hold, please. Hi, this is scheduling. I'm Sally. How can I help you?
Yeah, I need to get something scheduled for my daughter who has cystic fibrosis. My primary care physician, Dr. Freehill, referred me to you.
Okay, what's your child's name?
It's Olivia.
Can you spell that?
Olivia.
And what's her date of birth?
1/1/2001.
And what type of insurance do you have?
Blue Cross.
Who do you need an appointment with?
I'm looking for Dr. Moore.
Is that Dr. Brooke Moore or Dr. Steve Moore?
I don't know. It's Dr. Moore.
Let me see. Looks like Dr. Brooke Moore has an evening appointment in January.
January.
And it
Do we have
looks
anything
like
sooner
your-
than January? I've got to. It's October.
Looks like your insurance will be expiring in December, so will you have new insurance then?
Well, it's the same insurance. I don't know.
Because you'll need to check.
Can't you look that up for me?
No, I can't.
Well, how do I do that?
Well, you'll have to check back with your employer and see what insurance you're going to be on. And then you'll have to check in your network to see if Dr. Moore is someone that you can go to.
Well, can't you tell me if she's in my network?
No, not for your new insurance, but she is in your network right now, but she doesn't have any openings till January.
Well, what else do I need to do then?
Well, it looks like you also need to have a blood test done, and that would be with our lab, and a CT scan with our radiology center.
Where's that?
Well, they're next door to us, and you're going to have to make an appointment with them separately.
Why?
Well, we need to redo the CT scan.
Well, we just had one done on her 3 months ago. Why would we have to do another one? Isn't that expensive?
Well, yeah, it's about $1,200, and we need to redo it because Dr. Moore likes to have everything done by this radiology who is right next door to us.
But we already have one. Isn't that means I have to pay another $500 out of pocket?
Well, I don't know about your insurance. That's your insurance policy.
Okay,
so
look, I don't have time. I'm kind of doing this. I still need to call the infectious disease doc. Can I just get back to you at a later time?
Sure. Just call me back when you get all this done, and we'll help you out here.
Okay, well, fine. I'll call back later. This is frustrating.
Sorry.
Okay, hold on. Just one more, you guys. Bear with me.
Infectious disease, this is Steve. How can I help you?
Yeah, this is Chad Johnson. I'm trying to get into an appointment for my daughter. She's not feeling well. She has cystic fibrosis. Can you help me out here?
Sure, I'd love to help you out. What's your daughter's name?
It's Olivia.
Can you spell that?
Olvia.
What's her date of birth?
1/1/2001.
Now, has she had a CT done and her blood work done?
Well, yeah, and I'm supposed to get another one done, and I don't know. Can you just get those records from someone else?
No, you're going to have to supply those records to us. We don't
Okay.
have time to get records.
So how do we do this? When can I get in?
Looks like, hold on, give me one moment. Looks like we may be able to get you in late January, early February.
You know what? I'm just going to go to the ER. Forget this. So, Just a little thing. This is care coordination at its best. How many people know this game? Healthcare. So thanks for bearing with me a little bit on that. Who's played that game before? And if you haven't, I guarantee you, if you have kids or something, you'll play that game at some point. So I kind of like this thing. Sometimes with where we're at, I think we can all relate to that picture a little bit. And so what I want to talk about a little bit today is how do we deal with reform? How do we navigate kind of how this is going? And what are some things we can do as we start building our network, working with systems, working with primary care and specialty and hospitals? How do we bring that together in a meaningful way so that we can really start changing the way care is provided, both in terms of cost, efficiency, and just most importantly, how do you take care of the patient and make it a patient-centered experience that works for them? So I'm not good at standing still. So I'd like to introduce you to Gabe. I think this is a picture probably a lot of you can relate to. Gabe is a patient at Children's up in Minneapolis, and Gabe has some problems. He's a complex kid. Gabe's mom actually drew this picture for us. She got so frustrated trying to tell everybody exactly what's going on with Gabe, and every little box, every little circle there is a silo that Gabe has to, and Gabe's family has to engage or encounter. So you can see those blue circles, that's just medical. But what people forget about is, Gabe has legal and financial issues. Gabe has school he has to interface in. There's a whole support network Gabe has to be interfaced in to handle his care. So when you look at Gabe, this is what we're dealing with. This is what we have to do better, and we can do better. We can do this. And so as a network, we started looking at this, and our overriding goal started saying, what can we do for Gabe? How do we change this picture? How do we make this manageable? So that's kind of what I want to talk a little bit more about here today. So what we are is we are a network in Minnesota. We're a clinically integrated network who is kind of redefining ourselves. In the past, we've been around, we were a loosely organized network of hospital, independent physicians, and employed physicians. So it's in the 11 county area. We're fairly large. We're all pediatric focused. About 225 primary physicians, 400 specialists, and the main hospital tenant is Children's Hospitals and Clinics in Minnesota. So we started looking about 3 years ago and taking a serious look and saying, how do we come together as a pediatric community, and how do we really start changing how we're doing things? How do we work the primary care groups that are independent and start sharing information with the specialists and with the hospital? So we spent a lot of time, well, almost 3 years, redefining how we're going to work as a network and redefining what that care model could look like. Some of the key services that we're providing and that we're going to continue to provide are, we do a lot of quality review. We do some payer contracting, and we're starting to get into the risk-based contracting. We'll talk a lot more about these things here shortly. We're doing the data analytics, so we're trying to get the data. Now, the biggest problem we've had as a network is there's data out there, but we have no way to bring it together. So the data sits in silos, and it's not meaningful data to actually do anything with. Referral management, group purchasing, we do clinic education, and we also have a contact center, which does nurse triage lines. We have about 53 nurses that kind of work in that triage line that we're providing those services for, which is leading to be a very key component as we get into managing populations. So those are some of the things we're doing as a network. This is sort of how we're interacting. And I'm just kind of trying to give you some background as we talk more about that. How do we pull all this together with CCMR? How do we pull this together with analytics? But the network here is at the center. And, we have a lot of physicians. We're interfacing with community clinics. So we've got probably about 70% of our membership is community-based independent clinics. Then we have hospital-owned clinics. We have a children's hospital system. Since we're pediatrics, in order to really form that full comprehensive care model, we need to work with adult ACOs. So we're trying to interface with adult ACOs and be the pediatric kind of caregivers for those adult ACOs. Then we have payers. Has anyone tried to work with all those groups together and make them work seamlessly? I've got something to say. You know,
Seamlessly, but try.
you try. So, you know, the phrase we've used a little bit is it's kind of like herding turtles. You know, people have talked about herding cats. At least cats can go very quickly in a direction once you get them going. So it's when you get all these groups together and trying to get them aligned, it's difficult, especially when you don't have any way to connect the points. So this is the world I think you are all looking at and struggling with and trying to look and say, how do we pull all this stuff together? Your own bubbles will look a little different, but I think it's a similar model. So what are we trying to do? So as we've been redefining our network and looking at what we want to do, we've tried to say, you know, we need to have some common goals. What do we stand for? So we want to build a model where we can have care coordination, a centralized model where the patient that goes to any of our members can have a seamless experience. They go to their primary care, they go to their specialist, they go to the hospital, the data comes with them, the data flows with them. We have people there to support them, so the patients aren't trying to manage it. Remember, Gabe, we've got to make that picture better. We need to really focus on our evidence-based outcomes, and we need the available technologies. We spent a lot of time looking at technology, so I'll get to that because that's kind of going to be the crux of some of this discussion. And then really the other goal is we have got to get the independent physicians and the hospital and the employed physicians to really work together to collectively improve quality and reduce cost in what we're doing. The other thing then is that we as a network said, and I've used this before, but you know, there's three kinds of groups out there. There's the first kind that sits around and waits for something to happen. Then the next group goes out and makes stuff happen. And then the third group wonders what the hell just happened. And so we're trying to be that group that says, let's try and help make it happen. So by doing this and rallying the whole system together like this, we found that we can start working with the payers and actually be at the table as they start looking at how are we going to redefine payer contracts, quality, and get on the front end of that so we're not just waiting for someone to tell us what's going to happen. Just a little pictorial of some of that stuff. Some of the things we're really focused on is we have an organization in place. We've got some knowledge and experience. That has to be kind of on our base. Then everything else that's going to hold up our network is really going to be we have to have the right technology, doing the right things, utilized in the right way, or none of this works. So that really has to be a foundational platform. Then we need to focus on the health of the patients. We need to focus on our quality. Are we doing the best care we can? We need to be efficient. We can't do 3 MRIs just because each physician wants their own MRI or CT scan because it's the current model sends people to do that. You know, we've got to be more efficient with our care. And then we also have an advocacy program that we're starting up where we're working with the legislature, we're working with kind of the political side of it to try and educate our lawmakers around what does this really need and how can they pass laws that will help this. So all this stuff is really based on the continuum of care. We have to keep that continuum of care at the forefront so that we're not building silos. We have to break those down. And then again, remember Gabe, he's at the middle. We have to keep the families at the middle of that picture and all this stuff. If we're not making their experience better, we're still missing the boat. Sorry, we had a clicker, but it wasn't working. So technology selection. We quickly realized in order to make this happen, it's really easy to talk about, but I think that the gap that we've all had is fractured technology in a multi-EMR environment. How do you get this information? How do you pull clinical data for quality? How do you pull utilization and claims data so you can understand what kind of costs do you have around the network? How do you make that happen when you have multiple EMRs? I don't know. We were struggling with it. Population health technology was very fractured. We started interviewing vendors when we started looking at the technology platforms and what can help us with this, I think we looked at 10 different vendors and spent over a year doing that. What we found was there's some vendors out there that can pull data and give you reports. Then you ask them, well, how do you use that and engage physicians? Well, that's coming. That's down the line. Or we found some software that did a good job of care management. We said, well, great. How do you get the data into that? How do you figure out which patients you need to manage? Well, that's your job. You just put the patients in there. Then you can do it. We found lots of good siloed technology partners. We couldn't find someone that had a vision to really bring it all together. We were looking for a unified platform, and we found that was very difficult to find. We were also looking for digital health. We were trying to find, how do we use digital health? We kind of changed, it's more than telehealth, it's more digital health. There's a lot more to it than just telehealth these days. We were looking for someone with a track record and a vision. Someone that had a bigger vision than just saying, we're going to produce great reports. Where is the vision? So these are the things we were really focusing on as we were doing our search. And so like I said, we spent probably a year, and we struggled. And right before we were going to sign a contract, this is where we got kind of steamrolled by Rohan and Garish. I got a phone call that said, why are you looking at our product? And I looked at it and I said, I didn't even know you had a product. What product? You're an EMR company. So we then kind of stopped the show a little bit. They came out and started showing us this product. And we started seeing very quickly, although it was a new product at the time, and it's still a fairly new product, there was a unified vision there that no one else had. And so we kind of stopped the process a little bit and started over on that search. And so what we came to is, when we started looking at it and working with them, we started seeing that the CCMR and analytics tools, we went down that approach, looking at it to say, first and foremost, what do we need to do? We need to go out in the community and we need to aggregate data from practices, from payers, from lab companies, from the pharmacy benefits. We need to get claims, clinical data. How do you do that? So they have the tools and the technology to do that. Then we said, okay, we have the data, what do we do with it? So we need to be able to really figure out the utilization and run analytics. That's where Arvin spends 20 hours a week, or 20 hours a day, I think, running analytics for a whole bunch of practices right now. So it's been an amazing tool to start defining our populations. That drives into our quality and our outcomes. That data then shows us in real time with physicians, we can show physicians, here's how you're doing on your quality measures every day. You can see the gaps. You can see which patients are missing or why you're not meeting that measure. That's all, it all kind of builds in. Then we've taken, and we've done a pilot right now with, we've got a pilot with the state of Minnesota of about 16,000 patients. So we loaded that whole population in the analytics system, and using the risk-based models, using the scoring, using different tiering tools, we were able to identify about 2% of that population that really we want to start managing care on. And so now we are taking that information and really focusing on target populations to manage care with. And so that's building into the care coordination model. Then the last thing, that's all great, but until you can really engage those patients at the point of care, you're never going to change care. I think Garish said it, in the keynote. We live it, we see it. You have got to be able to work and engage care proactively and not wait for it to happen. So this is where the Helo tools come in, where you can actually go out and send that patient home on their iPhone, and they can be entering in their glucose numbers. Those glucose numbers come back out of a range. Guess who gets notified in real time? Your coordinator or the physician. So now you're able to actually be proactively monitoring, proactively reaching out, and you're closing that loop, and it all comes back together. So this is we did stop the show on what we're doing, and we did change directions, and this is our technology vision. This is what we're using, and this is what we're going forward with in order to build kind of our vision of an integrated network. So where are we today? We have pilots with about 70 clinicians. We're still getting started. We are doing the analytics and the utilization review, and we're starting to build our CCMR tools. And like I said, we have our pilot scheduled for December this year to start managing that first wave of CCMR patients. So now, let's be honest. It all sounds good, but it's not easy. So, in all honesty, I want to talk to you a little bit about what are some of the challenges we faced as we've been going down this journey. And this is where, think about questions, because this is where you get into the nitty-gritty. This is where you get into the heart and soul of what you're trying to do and the challenges. So, one of the biggest things we found, consents. Minnesota has very stringent consent laws above and beyond HIPAA even. And so when we have 50 member practices and you start looking at all the different consents, it gets to be kind of a scary thing. They're all different. We had one practice that the consent was so old legally they should have been treating patients. So we had to get that fixed right away. And we have had the luxury of having a really tight group, and these clinics do understand working together. So we're working toward implementing January 1 common consent that all these member practices can use, that includes all the different pieces to make sure we can share data, have data, use it throughout the network. But it's a challenging process. So if you're going down this path, do not underestimate the consents and getting that in place and being able to track them. At least in Minnesota, it's not okay to just have the consent. You have to actually track it with the date so that you can show that these consents have been done. And I don't think anyone wants to get into data disclosure issues. That gets tricky. So consent process. Don't underestimate that. Network dynamics. If some of you are looking at integrating networks between independent, employed hospitals, there's different incentives out there. And so it's a challenge to align those incentives between all those groups. You have hospital not-for-profits, you have for-profit clinicians. That can be a challenge. And so it takes a lot of time to align those. You have to really push that vision. It's newer technology. This population health, this stuff hasn't been out there for a long time. We're to the point now with EMRs where the EMRs sort of just flow. They sort of take care of themselves, they're upgrades, but you kind of know what you're getting. This is a work in progress. And in eClinicalWorks, we were the first pediatrics partners, so we did form a development agreement. And so we know that we're going to be kind of designing this on the fly at some point. So although the development's kind of fun, because we get to sort of customize it a little bit for peds, and we're trying to reach out to other groups as well around the country to be part of that process. But it's a development process. The other thing is funding. Let's be honest, the money trees haven't grown very well lately. So it's, everything's cutting, and these tools aren't cheap. There's definite cost to them. So really pay attention to your funding sources, get that in place. We're working with payers to show them the vision and say, look, we put these in place. Look what we can do with these patients in managing utilization. Come along the journey with us and help fund some of this. So that's kind of the approach we're taking. So we're trying to get creative and redefine how some of these payment structures are made. Data exchange with non-eClinicalWorks, EMRs. In theory, you should just say, hey, there's a CCD record, there's claims, 835, 837s, we can take them in. Sounds good? Doesn't work that way. What we found is, I'm going to steal a Rohan thing, it's pitch and catch, like he says it. What we found was eClinicalWorks had the ability to take CCD records, claims files. That wasn't the problem. Some of the other vendors that we were using, they can create a CCD record to meet meaningful use, but what does that mean? It means you as a user open up the patient record, go to a visit, manually click a button that says create CCD, and you can print it out. There's no ability there for them to actually say, give me all the CCD for all the visits you had today and then send them out. We haven't found an EMR vendor yet that can do it. So we did talk to, without naming names, there were some vendors that said, well, we can develop that. It's $40,000. Love to develop it for them. So again, it's capabilities, And so we've come up with alternative solutions. The eClinicalWorks team has put together some data adapters that can extract that data for us. But again, that's part of that development thing. It's part of it's newer. There's a lot of assumptions out there. You just have to really think through them. So the data exchange is a big deal. It can be done. We are doing it, but it is a challenge. The other thing, the EMPI platform, right now you do need EHX in place. So if you're a system, in order for it to really share that data in a very meaningful way. So if you are looking at this, think about your EHX needs if you're on that and how all that ties together. So that's another another thing to consider on that one. So always remember though, we've run into this. Don't let perfection get in the way of progress. You're never going to get anywhere unless you take that first step. So I do encourage you, take a step. It's going to be a journey. You're going to go up, you're going to go down, but take that first step. We have to remind some of our teams that they want to figure out every detail before they get started. We'll never get started. So this is something that I do like. The other thing is, to kind of wrap up here a little bit, find your pony. So let me explain this. This was a story I heard. It was actually Ronald Reagan. President Reagan said this a lot of years ago, and it stuck in my head. And he told the story of a family that had twin boys. These boys were about 10 years old at the time, and one of the boys, eternal optimist. You could not get this kid down. He found good in everything. His brother, all the way around. The sky was falling. Everything was terrible. Just, this kid lived just stressed out all the time. So they went to a psychiatrist and said, "Can you help us with this? This is starting to worry us. These kids need to grow up." And the psychiatrist said, "No problem. I've got a trick on this. We'll take care of it." He said, "I'm going to start with the pessimist." So he took the pessimist, he took the first boy and said, "Now I want you to go into this room and just spend some time in this room. And in the room, there's it's kid heaven. He's got donuts, video games, every toy you can imagine. It's a great thing." So he left them in there, and within 5 minutes, the boy sitting in the corner crying. The psychiatrist says, "Why are you've got everything you need." He says, "Well, but what if I touch something if it breaks, or if I eat the donuts and I get sick?" He's just stressed out. So the psychiatrist said, "Hey, we're going to talk later. I got to think about this one some more. I'm going to go to the optimist." So he took the optimist, and he put him in a room just stacked full of horsemen, thinking, nobody can find good in this. This kid's going to get bummed out. As soon as he brought him into this room, this kid's eyes lit up like saucers. He got this look on his face, and he climbed right up to the top of this pile and just starts flinging this stuff, digging. The psychiatrist finally says, "What are you doing? What can make you so happy about that?" He said, "Sir, if there's this much horse manure in here, there's got to be a pony in there somewhere." So as I've been interfacing with hundreds and hundreds of physicians, and where everyone has their own attitudes, everyone has their own view on healthcare reform, what it is, whatever yours is, you know what? Find your pony. There's a pony there somewhere. Oh, hold on. Got to take this real quick. Hello?
Hi, Mr. Johnson.
Yeah.
This is Maria McGannon, and I'm a nurse care coordinator with Salt Lake Pediatrics. Dr. Freehill gave me your daughter's name. Is it Olivia?
Yeah, it
She
is.
has a recent diagnosis of cystic fibrosis. Is that correct?
Yep, that's true.
Boy, that can sure be kind of overwhelming, can't it?
Yeah, I can't even tell you the problems I've been having trying to get this set up and coordinated. It's about driving me crazy.
Well, I don't need to drive you crazy anymore, but as a care coordinator, one of the services we can provide is trying to help you navigate through the system, get some of the appointments set up, the lab CTs, and make sure that's all coordinated. And if you're okay with that, I'll go ahead, because she probably should see pulmonology, infectious disease. And if you're okay with that, I'll go ahead and get those appointments set up for you.
You know, you could do that for me?
Yep, I sure can. And through Children's Health Network, because we have everything integrated at this point between labs, we can share some of that data with the lab CTs, so we don't have to repeat a lot of the things that have already been done.
So that'll save you all that out-of-pocket expense to not have to duplicate everything?
I think it can. That's what we want to work
Great.
toward. Now, I also noticed that she's due for a physical and needs a couple immunizations. So here's what I was thinking. Why don't I go ahead and get these appointments set up? I'll get the lab, CTs, some of those things transferred to the specialist. It'll take me a day or two to get the appointments set up. And then let's have you come back and meet with Dr. Freehill here in a couple of weeks, and she can kind of pull everything together.
That would be wonderful.
Now, is she feeling okay right now, or?
You know, she's not feeling very well.
Okay.
So
Now,
we're
Dr.
wondering if we need to go somewhere else.
No, Dr. Freehill has an appointment this afternoon about 4 o'clock. So why don't we just put her in for that? You can come back and see her, because I just don't want you to end up in the ER for something you don't need to be there, and she doesn't need to have that kind of exposure to a bunch of other illnesses either.
Well, that would be great. We'll see you
Okay.
at 4 o'clock. And thank you, Maria, so much for helping us out. This
That sounds
really
great.
makes a difference.
You're welcome.
Thank you. So that's where we need to go. That's the presentation. I tried to keep it a little higher level, more on the vision side, but I want to leave a lot of time for questions. Thank you to the helpers here that helped do our little discussions. But at this time, I'd like to just open it up for questions. So please feel free to ask whatever. I'll be honest. And just remember, if you want to come here to the mic, just kind of say who you are, where you're from, and then feel free to ask whatever questions.
I'm Dr. Cesar Ortega, Houston, Texas, Pediatrics. Some of the problems that we're having, relatively speaking, in Houston is, like you said, we have a big children's hospital, and they're actually opening up their own clinics in some ways, and the insurance company is actually opening up their own clinics. And so for us, we're independent. I would just wanted to ask, can we be a part of that network, or is this just more of a statewide that you are running, if you will?
Like the Children's Health Network? Right now, it's just contemplated as being more of just a network, more local to the patient. So it's really more patient-based, population-based, so that we're managing patients and managing how they flow through our networks. So we really haven't thought or contemplated having it be outside of that. But I do like that idea at some point to really form up and have a super network. But I understand the concern with the payers and doing things and how do you. One of our goals is not to allow a platform, to allow physicians to, should they want to join a system, that's great. But for those that want to stay independent and be able to continue to have independent medicine, we need to keep a forum for that and be able to have that there. Because without having some leverage, some bigger utilities, it's very difficult these days to do that. So we're trying to give options and create those options while still having patient care at the front center.
Dr. Rani, Community Health Center in Georgia. Because we are a community health center, we are struggling to incorporate with all the other health entities out there and in the community, and we love to get on board with CCMR, and we're looking into this. As a clinic, first, before we jump into this, what do we need to prepare ourselves? What has to be in place before we are ready to get on board with CCMR and all of this?
So that's a great question. So the question is what needs to be in place? What do you need to consider before jumping into a CCMR type application? So the things that we did is back to that slide where I talked about is, number one, you need to understand who you're going to be working with. Who are the key people in groups, hospital systems? Who are you going to be working with? Because they're the ones that are going to need to sign up and share the data and then buy into this. So you need to get the vision out there of your network, of where these patients are going to flow, and you need to get that group engaged, because they're the ones that are going to have to share the information. So that, I would say, is first and foremost. Then you need to really start looking at building a core team of, I would suggest, physicians or clinicians that can really help drive this, both from an independent and a hospital. What you want to do is build this in unison and not just let it be slammed down or driven by any one entity. So really understand who you are first and get consensus and a vision together. And once you feel like your groups have a common vision, then, Arvid, Bohan, and the team can come in and really walk you through more of the technical components that need to happen in the technical infrastructure. But I think by far the most important thing is buy-in from the larger community that this is the direction we want to go.
Great job, Chad. I'm a pediatrician in the Philadelphia area, part of an ACO that has both adult and pediatric independent practices. When I looked at your slide, let's be honest, behind that, all I saw was a huge dollar sign. So if you could talk a little bit to the group about, first of all, how has ECW been in understanding the challenge of where we are and the cost involved of getting CCMR on board in an ACO that has no money up front, because until we show that we can do this, the insurers aren't going to pay us more. At least that's been our experience. And second of all, if you could talk about when you sit at the table with the insurers, what are they willing to give? Are you looking at a PMPM? Are you looking for an enhanced fee schedule on the PPO side? Are they giving you infrastructure support, that sort of thing?
Great questions. And at the end of the day, so much of this does come down to funding. It's just, let's be honest. So we've gone after this in a number of different ways. So from a network, from what we have is to be part of the CHN, there is each clinician pays dues. So there's due structures. Now that's not the majority of the funding needs, obviously, but that's part of it. We do have some contribution from our hospital partner that helps with some of it, knowing that this is good for the hospital as well as it is for the patients, because you're building a network where you're managing populations and it affects everybody. So the hospital's been supporting it. When we go to payers, we currently have arrangements with the payers in place that we are trying to redefine right now. But for starters, some of our payers do pay what we call negotiated as an admin fee. So we've given them the vision of what we're doing. We show them as a network, here's how we can start managing populations. Here's how we can start managing this. And by you investing into this and helping support us, we can drive these kinds of savings, and it is a win-win. We have negotiated some withholds on payer contracts. So what we've done is we've said, here's our quality metrics that we're going to meet. They withhold 5% of the fee schedule, so there's a risk pot. And if we meet that risk, that money comes back, and then that gets paid back out to the physicians. But as a network, we take 20% of an admin fee off that risk pool. So we're using the risk pool to fund some of our operations. Now, as far as the question is, how has eClinicalWorks been to work with building this? Our initial discussions, financially. So my initial discussion with them was, I love it, I can't afford it. Sorry. And then they came back and said, well, let's figure out what we can do and how can we structure this. So I do have to say, Sam Bott and the team were very willing to get creative with us to help us put together some ways to fund this. They had no feeling that this is a price tag or anything. They were willing to work and develop and get creative, and I think I would encourage you to be honest and say, this is where we stand financially. We want the product. Eventually, we know we can get here, but how do we get this started? And I would, not to put words in their mouth, but they showed us that they were very willing to do that. Is that fair?
What's the admin fee more or less the range that we're negotiating or being negotiated?
Is it a PMPM fee for this admin?
Oh, we have a couple different ways. So some of them is a PMPM. So we have a PMPM fee, so for whatever we hold contracts, so they pay, X dollars per member per month. I think it's $7 or $8. So it's a goal of our network is we currently hold a few insurance products. Within the next 3 years, we want to have all the at least starting with primary care, all the insurance products running through the network, including all the hospitals. So we'll have then the 650 physicians of ambulatory. That gets to be a pretty big member base, which then we can get more and more creative with the payers and more creative because we can really control some of those populations. But we've got a lot of different ways that some payers want to do PMPM, some payers want to just say, we're going to give you X dollars. It really depends on the payer. We don't discriminate when they offer this. But it's been a challenge to, payers, here's the other difficulty, and sorry, I'll get to it in a second. The other difficulty is, we've had 1 or 2 payers, most of them have been really good with this. They really engage in it, they see the benefits. One of them is terrified to give us data. And what it comes down to is, they realize, because now instead of negotiating with 50 groups, they're negotiating with 1. And by giving us data and us having this information, we know more than they do for the first time ever. Because usually we're at their mercy because they have the data, we don't. Now, with this kind of information, we know what they do except more because we also have all the clinical information that they don't have. So it's new for the payers. They're trying to feel this out and figure it out, how to make it work. So the key here is, if we just try and hold a big stick at them, it's not going to go. It has to be a partnership with the payers. We have to work together in a very collaborative manner with the payers because ultimately, if it's just a street fight, I don't think we're going to be successful.
Thank you. Norm Tangway from pediatrician from Wilmington, Massachusetts. Getting back to the EHX, can you talk a little bit more about what kind of interoperability you envision with your practices that have EMRs other than eClinicalWorks and also with the hospital EMR systems?
So interoperability between other EMRs?
Right.
And then the hospital system.
Right, with your EHX stuff.
Yep. So we went down, we did this a little bit backwards. We started out by not doing EHX and tried to go right to CCMR and analytics and realized we really need the EHX hub in place in order to really make it work the way we envision it. So we're building it right now, so I want to kind of have that disclosure. But our vision of where we need to go with that is we're never going to have that same tight integration between next-gen and eClinicalWorks as we would internally. But what we want to at least be able to do eventually is at least be able to get to that CCD, right? At least get to being able to embed links or embed inbox messages when something happens on a next-gen practice. Now, the EHX Hub will also give us the ability to pull all data and have it available in CCMR and analytics, so we'll have that. So from an EHX or longitudinal record view, a non-eClinicalWorks group will see it there. They'll see the longitudinal view through CCMR, but they won't necessarily see it through EHX. From a hospital standpoint, we need to have a much tighter integration with the hospital. Ours is Cerner, Children's is on Cerner. And so we are starting processes, will be very soon, where we're going to be building full integration between eClinicalWorks and Cerner using the EHX Hub to do that. So how all that's going to exactly look at, whether it's HL7, which I'm assuming a lot of it will be, but that'll be a much bigger integration work effort. But that hub is the part of it. Does that answer a little bit? Or does anyone else, Rohan or Arvind or anyone else want to talk a little bit about some of that? Or we okay? But we can talk more after tonight.
Ismael Toro from ACO Puerto Rico. It's an adult ACO. I just wanted to applaud you on your efforts and what you're doing with Children's Health Network. So, and I would also like to comment that in our experience, which is just this year, obviously the commercial, we have a Medicare ACO or Medicare A and B contract with CMS. We have very few lives, like only 8,000 or 9,000. But what we found out is that the opportunity for moving to the commercial area is extraordinary. And right now, in less than 2 months, we have 3 insurance companies that are willing to pay us a small amount for an admin fee, but give us even up to 50% of the savings of that population that we will be managing. So for those that are considering the CCMR option, and we're just starting, we just signed the contract, we're just in the process of implementation. We also went through going and looking into different tools for the alcohol population and the integration of all the elements that you have very well summarized. And I really thank you for your presentation. I just wanted to bring up that there are other options for financing, and quality is always something that the insurance companies are looking for, since they're being measured heavily on their performance.
Well, first of all, thank you for your kind words. It only happens with a huge group of people and very invested physicians in the community. That's been first and foremost is a very invested community. So it doesn't have a lot to do with me up here. It has to do with a very invested group wanting to do the right things. We found it's funny that you said that payer, our biggest payer in our market, who a number of years ago, before I was involved, pulled their contract from the network, and so they wanted to negotiate independently with every group and no longer hold a network contract or pay any admin fees to the network. Since we went down this path and we were talking about what we're doing in this vision, suddenly even at their kind of senior vice president in charge of all of the entire payer contracting groups is requested meetings on how to re-engage in data sharing, how to re-engage and come back to the table to be a really meaningful player in doing this. So they, like I said, some of the payers are seeing this and they're willing to work on it too and do these 50-50 sharing plans. It is there. We need to be bold and go for it.
Brad Blunt, family physician in Central Florida. Quick question. I know from talking to at least some other physicians that are using the CCMR for their ACO through eClinicalWorks, that doesn't seem to interface with the state HIE, at least not Florida and some of the southern states. In our area, the hospitals don't have that working relationship with the ACOs, kind of trying to, turn the backs to all the ACOs that they try to get them to disappear. So with us, our ACO that chosen was involved in this, but it chose a software that was already interfaced with the state HIE, so we could get instant notification, almost instantaneous notification when patients were admitted to the hospital. So we could start looking at a nurse and case manager on right away, make sure the care is working. We go to the specialist they're supposed to, and we get the follow care they need. But it doesn't have any workflow templates that clinical software has. So what do you do with your patients who end up getting admitted to hospitals that are not in the local area or not hospitals that you have that interface with? How do you track them and get the care under control?
Well, that's actually a very easy question. We don't. And I say that, kind of tongue in cheek because what we have is Minnesota doesn't have a state HIE. They've tried multiple times to get something together, but there's just never been the adoption. They just haven't been able to pull it together. The big systems just haven't gone there. So what we're finding is, it's becoming more network focused. And so for us to get to that point where if patients go outside of the system, we're going to have to rely on payer data coming back in to show us where those patients were. Ultimately, we've started some of these discussions as some of the other children's hospitals, there's a couple of them, more of a specialty center and then a university-based children's hospital, actually starting to build some sort of data sharing integration between them, knowing that even though they're competitors, sometimes the right thing trumps competition for the patients. And so that's where we're trying to go with them, is to try and get that exchange in place when patients do go back and forth, because without it, we really truly are not serving that patient quite right. So we don't have that part figured out yet. We're getting good at the network, but when they go outside the network, we don't have that same capability to get that information at this point. So that's a future consideration.
I'm Carla Knoll with the Villages Health, physician of Villages Health. Your slides, and even in your talk yesterday, talked about the fact that you're in a pilot situation with this for the CCMR. How long are you looking at going out of the pilot stage and actually doing the full implementation? Or do you even have
Arvin, how quickly can you turn it around for us? No. What we're doing is, so our analytics, we kind of are live there. We're getting it built. So when we say pilot, what we wanted to do is start with a couple of clinics. Now the clinics we started with are larger, so that's 35 clinicians, 20 clinicians. So we needed that pilot to start and really understand it. So by 2014, we'll kind of be live on the analytics side. Our pilot CCMR and care management this is new for us as a network. We haven't been doing this. We've done bits and pieces. Some of our individual clinics, one of our partners, South Lake Keys, was here that was helping me with the phone calls. They're a medical home, so they've been doing this, and so as a network, they're helping us build strategies so that we can have a centralized model in place. So 2014 will be more pilot mode for us as far as only doing care management for some select populations and working through a little smaller group until we get good at it. And then as we can centralize this and get all of our clinics involved, start rolling it out and like I said, get out of more of a pilot mode into more of a, so even though it's pilot, it's still operational. We'll still be in operations, but it'll just be on a smaller focus thing. And then over the next 2 to 3 years, we'll be expanding this and including more and more conditions, more and more things. But again, don't let perfection get in the way of progress. We need to just pick something and just take a step. And then when we get there, maybe we can go sideways, but then we gotta take another step. So eventually we're gonna get there, but it's gonna be a path to get there.
I just wonder how many of your primary physicians are patient-centered medical home practices? That model implemented.
So we have, and again, the person right behind you is probably much more an expert on this than I am in Minnesota, but we don't have any patient-centered medical homes. We're more of a, it's a very similar thing in Minnesota that we have, but it's a very small percent. So currently, I think more will go to that, but currently of the 20-odd primary care groups that are part of this, I think only 3 of them right now are medical home certified.
Okay, so I just wondered, and just wanted to comment 2 things about the patient-centered medical home model and about the exchange with the state system. In our ACO, we required for 2014 all of our physicians in order to get full chair savings participation to be PCMH certified. And surprisingly, out of about 500, next week we'll have a meeting with about 150 to 160 that have confirmed for a first training project for the PCMH. And I think it's fundamental because it will permit the practices to establish their particular capabilities in doing care coordination, and then so that we can establish a kind of a stepwise model where they can provide some of the care coordination services and be reimbursed and obviously have financial incentives for that execution. Our particular model is running that way. As I told you, we're just starting. As a matter of fact, our ACO is administering this program only for the last 2 months. But the other comment is about the health information exchange with the states. And I don't know if you will have the same situation, but in ours, the state health exchange is pretending to have lab information and other provider information to roll up to the hub and have us go to the hub to obtain some of that information. And we have emphatically opposed to that model because there is no way without a clinical validation by physicians or other professionals that are qualified in the health field that health information for patients should go to any hub to establish probabilities of diseases or conditions without any clinical validation. So we are totally opposed to the exchange until our criteria of how the elements of qualifications for all the diagnostic process are going to be taken into account, and obviously an even bigger challenge, how our patients participate in authorizing that exchange. And we adamantly oppose to any process that is not considering those 2 elements as fundamental to start the exchange process.
And those are good comments. I agree on the PCMH. One of the visions that we have as a network is to be sort of to be able to help practices provide a blueprint to become medical certified, because I do think that is a key element as we're trying to manage populations. So that is an area we need to go. The other thing with the exchange, I think we talked a little bit about earlier too, is that is one of the problems is why our states never really adopted it, because how do you pull all that data, and then what's the source of truth? Who's validating it? So there's a lot of issues, which is why the networks are tending to do it on their own and trying to get to that area on their own. So I think I got the sign that says we're out of time. Thank you all for listening, and if you want more information, come around. Thank you.